फिर उस टाइम लगा देना फ्लाइट कैसे आगे बोलो
सर पॉइंटर इधर वाला सर लाल बटन हाँ जी.
Good afternoon everybody from Surgery 3. Today we are going to be presenting a CGR on surgical challenges in inflammatory lung diseases. And why we chose this topic was, इसका आगे कहाँ से होता है? So first, this is a Facebook post by Dr. S. Bal, who was one of the persons who who kind of pioneered thoracic surgery at AIMS, besides Professor Chatterjee. And this post came this October only, nearly 12 years after an incident that happened. And this is an incident about a young man called Sushil whose left lung had been devastatingly destroyed by tuberculosis. And he suffered recurring attacks of hemoptysis and pain. Like most of our patients, thin, pale and frail. He came in April of 1994, had already had 2 attempts at thoracotomies. But people did not, proceed with surgery. They opened and closed and they just couldn't finish the procedure because of density. And this is one of the major problems that we have in all these inflammatory lung diseases. How can this be? I thought. I was full of confidence, just returned from UK. Obviously thought too much of myself. Admitted Sushil for surgery, telling family I would be able to do it. Surgery went on smoothly for most time. I had mobilized the lung over 3 hours and was now ready to tackle the hyaline structures. Suddenly there was a huge gush of blood. I had a valve pulmonary artery. Before I knew I could do anything, Sushil had bled to death. I went out and spoke to the family. In that wretched moment, don't know what I said and what the family heard and understood, except that Sushil was dead. I brooded over it entire day. The feeling of depression was like a cloud covering my entire being. Now you can kind of well imagine that 1994 this incident happened, and 2016 it is still haunting him. And this is what happens to all of us as surgeons. This is something which never leaves us. A person who dies on table, a person who bleeds to death, a person who gets very severe complication, it stays with us years and years after it has happened. And that is and this is the problem which actually happens, or which is a potential risk in inflammatory lung diseases, and that is why we thought we'll share our experience with you. And so it's inflammatory lung disease is basically a kind of disease of third world, predominantly affecting people of poor socioeconomic status, productive age group, and it is a huge social and economic burden. It's kind of a cluster of entities: post-tuberculous sequelae, aspergilloma, fibrothorax, bronchiectasis, emphysema, hydatid, Gould's disease of the lung. It's intimidating both for patients and surgeons, and entails very, very complex surgery, very high risk of complication, including death, and even sometimes after you've done the surgery, the quality of life may not necessarily be very great. So I'll give you some scenarios, some happy scenarios, such as this 30 years old female with an aspergilloma, BMI 23, complete hemoptysis, a good FEV1, an X-ray showing a small lesion here, and this is a video of the surgery. Correct, please. Can you bring it down and play it. So this is a very, very unusual situation. You look at a lung which is absolutely clean lung, there are no adhesion, you can nicely see all the structures. So उसपे play करो, उससे हो जाता है. Okay, we'll skip it. So the surgeries go smooth, the procedure is completed with VATS approach, post-op good X-ray, patient goes home on second day. This is an exception in inflammatory lung disease. We don't really get to see these kinds of things. Take the other scenario, 50 years old lady, 16 BMI. A very common situation that we face. Hemoptysis, FEV1 1.4. A CT scan of the chest shows a lesion here. Now, this is also not playing, so I can't really help it. But this patient, we started VATS, and soon after we started, she started bleeding. Dense adhesions, converted to open surgery, kept on bleeding, surgery completed. She still kept on bleeding from the chest wall. Received 12 units of blood, bled again in the ICU, re-explored, 4 days of mechanical ventilation, 7 days of ICU stay, post-op stay of 11 days, eventually went home. But it was a near miss kind of a situation. A third scenario, a young boy with a aspergilloma, planned for cavernostomy, intra-op cardiac arrest, resuscitated, procedure one done. Again, a second attempt at cavernostomy completed, developed BPF, third surgery, pneumonectomy with the help of CT-based surgeons, 17 days of ICU stay in the third surgery. And this is, and after all this is what you have. The question is this better than the disease itself? So this is an outcome sometimes we get to see in these patients. This is another very common problem that we see. A 19 years old female, FEV1 of 0.8, thoroughly investigated for surgery, cleared for surgery under high risk. Aspergilloma, destroyed upper lobe, left side, a large bulla on the right side. Taken off for surgery, surgery completed relatively uneventfully. Post-op, the lung would not expand. The remaining lung is so diseased that it would not expand. Discharged, came back with a big collection, a pigtail inserted. After a few days, the lung expanded to an extent, but it will probably never fully expand. She still has a bulla for us to deal with. A 35 years old young man diagnosed as aspergilloma, BMI good, FEV1 good, right upper lobe kind of completely destroyed. At surgery, dense adhesions. There's some problem with this. Dense adhesions at surgery. This is automatically running now. Is there some problem? Lost a lot of blood, and the mind, they don't, one is that a person loses blood from the hilum, okay, that's a disaster, but then you can still control it. These people lose blood from the chest wall. You cannot see the blood vessel, it just keeps oozing. There is no way. You use a ball, you use a cautery, you use pressure, you use harmonic, it just keeps on bleeding. Anyway, lots of blood loss, 3 liters of blood loss, patient went to ICU. First post-op day, everything looks fine. Second post-op day, there is a total whiteout of the middle lobe, the remaining lobe. Do a CT scan. What we suspected was, initially it was thought to be a consolidation, but we kind of were worried that consolidation, would it occur like this. One day he's fine, and the next X-ray is totally opaque. Got a CT done, discussed with Dr. Raju, and the suspicion that we had was that could he have had a torsion of the middle lobe? And this is the CT scan which shows there is no perfusion of the total cutoff of all the vascular supply to the middle lobe of the lung. And patient then was re-explored, and the middle lobectomy was done. 2 thoracotomies, 26 units of blood and blood products used. However, patient eventually went home well, but a lot of morbidity. And this is lastly, I mean, things like hydrated, they just keep coming back. This patient when he came to us, he had already had 2 or 3 operations done, abdominal hydrated, chest hydrated. We also did, and now he has come back with another hydrated. How long can you keep on going such patients? How much can you keep on going? With this, is Dr. Puneet here? Actually, Dr. Lokesh's father passed away today morning. He was supposed to give this presentation and he has sent it, but because his father passed away, so he's not been able to come. I would now request Dr. Guleria to come and give an overview from the physician's aspect and the problems, the burden of the problem. Dr. Guleria.
What I'm going to be talking basically is from the physician's point of view as far as the burden of disease and the preoperative workup is concerned. If you look at common diseases which would come under the category of inflammatory diseases, as we have sort of the rundown is all about, the diseases that we look at are bronchiectasis, lung abscesses, empyemas, which are pleural diseases, post-tubercular sequelae which lead to a number of issues as far as surgery is concerned, a fungal ball aspergilloma which has its own challenges as has just been mentioned. Then we have bullous lung disease where you have bulla which are getting recurrently infected, and not that uncommon, but it's interstitial lung disease which are not purely inflammatory disease or from the infective point of view, but sometimes we get a diagnostic VATS biopsy done to find out what is the etiology or the underlying cause as far as the ILD is concerned. So challenges for a pulmonologist is when we see the patient is when to consider surgery as an option. When should he send the patient to the surgeon that this patient would need surgery? And then what is the surgery that needs to be done? Is it segmentectomy? Is it a lobectomy? Or do you need to take the whole lung out? Is it a pneumonectomy? Second issue is the patient fit for surgery? Do you in your mind feel that this patient will withstand the surgery and with all its morbidity and mortality? And what optimization should you do prior to surgery? And then is there a need for intraoperative assessment, as you may need sometime, and the postoperative complications that can occur? Now, if you look at bronchiectasis, which is the commonest or one of the common disorders, it's actually a disease, as Professor Rajendra Prasad mentioned, which we see much more common as far as the developing world is concerned. The developed world tend to see a lot of non-cystic fibrosis related bronchiectasis. We see a lot of bronchiectasis which is post-infective. It's basically a permanent, irreversible damage or dilatation of one or more bronchi. And if you look at the literature, depending on series and which part of the world you are in, it may vary from 4 to 272 per lakh population. So very wide variation depending upon what is the type of baseline population that you see. Sparse data from our population as far as prevalence is concerned. Like I said, more common cystic fibrosis in the Western world, and post-infective is much more common in the third world. You need to keep in mind that many of these patients may have some sort of an immunodeficiency which may present in later life, and that may lead to recurrent low respiratory tract infection presenting as bronchiectasis. Another disorder that we see relatively more common as compared to the West is allergic bronchopulmonary aspergillosis, which is basically an issue with which occurs in patients with asthma who have aspergillus hypersensitivity, and in them we see a lot of central bronchiectasis, and this is actually not an ideal case for surgery because the underlying disease will continue and ABPA needs more medical treatment than surgical treatment. This is just to give you this huge list of causes of bronchiectasis, from structural lung disease to infection. In our setup, infection tends to be more common, to obstructive lung disease with recurrent infections occurring, and then you have various other causes like toxic inhalation injuries, mucociliary clearance defects, immunodeficiency, and if you don't really find a cause, sometimes you have idiopathic bronchiectasis. You have various classifications which I'm sure the radiology will cover, but basically trying to look at it, is it a localized disease? You can have cylindrical, cystic and varicose type of bronchiectasis. All can be present in our setup in our patients that we see in day-to-day practice. Coming to surgery for bronchiectasis, usually surgery would be done if it's a localized disease. If it's a diffuse bilateral disease, surgery is actually out. Or if you have a disease progression despite optimal treatment. So the disease is showing that you have serial scans or serious x-rays, and it shows that despite optimal medical therapy, the patient is developing recurrent infection in new areas of bronchiectasis. So you want this diseased lung to be out because this is acting as a source of spillover of infection to the otherwise healthy lung, causing more and more damage and decline in lung function. And if the patient is failing medical therapy or not tolerating medical therapy, which would include recurrent courses of antibiotics, chest physiotherapy, postural drainage. And then the issue is, what is the type of surgery? Lobectomy, segmentectomy, or pneumonectomy? Non-anatomical resection like wedge resection is usually avoided in these patients. An incomplete resection has the greatest risk of failure, and again that should be avoided. So you must be clear as to your surgical plans. And the other thing to remember is, because of recurrent infection, and if it's a peripherally situated lesion, it will cause a lot of pleural adhesions, which will lead to problems in surgery. Also, bronchiectasis, because it causes more hemoptysis, leads to a lot of neovascularization or in the bronchial tree. So there is a lot of vascularity around the area of bronchiectasis, and there is vascular hypertrophy, which itself causes a unique problem as far as bronchiectasis is concerned. This happens also in patients with aspergilloma. Aspergilloma, the fungus, causes two very classical things. It causes a lot of neurovascularity. So if you look at surgical patients who go for treatment for a fungal ball, they will tend to bleed much more. Also, it leads to a lot of surrounding fibrosis. The surgical planes tend to get lost, and again, it's a big challenge for surgeons. So if you look at the data which is available, and you're looking at thoracotomy and VATS in various series over the last 10-15 years, you'll find that gradually the mortality has varied from about less than 1% to about 1.7%, and with VATS guided procedure, actually the mortality tends to be much lower, almost 0%, and complication rate is still high to some extent. Then coming to lung abscess, it's a severe localized suppurative infection in the lung associated with necrotic cavity formation. So you have a necrotizing pneumonia, which leads on to a cavitation and formation of lung abscess. If you look at previous data, and this is old studies, it used to suggest that 16% of total thoracic and cardiovascular admissions were because of lung abscess. But this incidence has come down significantly as in the last 2 decades because of aggressive and good antibiotic regimen. So we rarely get our lung abscess patients operated nowadays. Treatment remains IV antibiotics, and they actually do very well with that. But you will have a small segment of patients with lung abscess who may require surgery, who do not respond to medical therapy. The abscess is closed, it's not draining into the bronchus, and therefore they continue to have this pus collection which causes fever and symptoms. You may also have a lesion that you may suspect that this may be a cavitating malignancy. It may not actually be an abscess, but a cavitating malignancy. Or there may be an underlying congenital malformation which is predisposing to or behaving like a lung abscess, and therefore then in such a patient you would need to take it out, and lobectomy usually will suffice. The other common indication, and probably quite common in our setup where we have a big challenge with our surgeons, is complicated effusions in empyema. Empyema basically by definition is pus in the pleural cavity, and it's been reported that almost 20% of patients with a community acquired pneumonia will develop pleural effusion, but that may not be complicated pleural effusion, it may resolve on its own. And 30% of these, the effusion may progress to what we call is a complicated parapneumonic effusion or an empyema. Also remember that this is related to non-tubercular infection. Tubercular infection will also lead to features of an empyema, and this usually requires IV antibiotics and pleural drainage. If you look at data, there's an increasing trend of parapneumonic empyemas and hospital admissions over the last few years, and this suggests that it's predominantly in the elderly age group of people over the age of 65, but overall there is actually an increasing number of patients that we see who have complicated effusions and require surgical interventions. Debridement, decortication remains the mainstay of treatment. We do a lot of other things before we send the patient to surgery. Good antibiotics, we get a chest tube in, try fibrinolytic therapy, and try to get all the pus out and break the loculi. But if you look at the guidelines, and even if you look at major trials which have been done as far as the role of surgery is concerned in empyema, surgery is recommended in all patients who have complicated parapneumonic effusion which is not responding with aggressive antibiotics. So persistent sepsis, evidence of pleural collection despite proper drainage and antibiotic treatment, is an indication for surgery. progressive to advanced fibrotic stage, there's a thick pleural peel, the pleura is thickened, the lung has got entrapped. Again, surgery is a treatment of choice. And therefore, about 1/3 of these patients who have paranomic infusions or complicated get referred to surgery when medical treatment fails. Various series have looked at complication rates and have looked at streptokinase versus VATS. And if you look at the VATS guided success rate in terms of failure of conventional therapy, in terms of hospital day and mortality, VATS guided treatment actually has done much better as far as treatment of empyema is concerned. But the important thing to remember in empyema is that the timing of the surgery. When should you do the surgery? Traditionally, people would say that as early as possible, because remember, once a pleural peel has developed and the lung has got entrapped, then there is a significant degree of alteration in the chest wall. So crowding of ribs, flattening of the chest wall, drooping of shoulders will start, and often if you delay surgery, that will not get corrected. But it's a messy surgery then, because then you have a lot of pus in the pleural cavity, and it's something which is difficult to treat because it's difficult to manage as far as surgery is concerned. The other is to do it late, once the pus has dried up and now you have a thick fibrotic peel, but by that time the patient has already developed a significant degree of chest wall deformity, but at that point in time there is hardly any pus, it's more of a thickened pleura which is left, and therefore decortication can be done. Most people would say that the earlier the surgery is done, it's better. In our setup, we tend to at times do surgery late rather than early. But possibly, I think we need to look at sending some patients who start having a lot of pleural thickening and loss of lung volume early as far as empyema is concerned. Another issue is post-TB sequelae. Pulmonary tuberculosis remains a major problem in our country, although we have an aggressive RNTCP program, but still we see a large number of patients who have tuberculosis and its sequelae. Parenchymal lung destruction is common. We see extensive fibrosis, fibrocavitary disease, destroyed lung, and all of this along with residual cavities actually leads to a number of complications, from bleeding to fungal wall formation to patients having recurrent lower respiratory tract infection. Tuberculosis, predominantly for a number of reasons that we all know, is an upper lobe disease. It can also lead to airway involvement like bronchial stenosis and post-bronchial stenosis recurrent infection. And very often, although less common, but we still see a lot of patients who we say have extensive tuberculosis of one lung, and it's actually what is called as a destroyed lung. Surgery in these patients is usually required when there is recurrent infection occurring in that area. And I think here we need to also look at the utility of surgery in patients who have drug-resistant tuberculosis. Now there is a large body of data which suggests that if you have an MDR or an XDR TB patient and who has a localized disease on your chest X-ray, your overall cure rate will be much higher if you combine treatment with surgical resection, because you're decreasing the bacillary load by removing that part of the lung. So if he has a localized cavity, he has extensive tuberculosis which is not responding, or he continues to be having MD or XDR tuberculosis, it's a big challenge because it's an infectious patient, surgery itself, or you need to have a lot of infection control measures. But overall, wherever these studies have been done, and there are series available, show a very high cure rate when you do surgical resection in MDR and XDR TB who are fit for surgery. Then we have the issue of aspergilloma formation. I've already mentioned that this is something which is a big challenge because of various issues. We see a lot of fungal balls. We do a lot of things from our side. The radiologists do bronchial artery embolization if they have recurrent hemoptysis. We do intracavitary instillation of voriconazole as a sort of off-label treatment for fungal balls, that we bronchoscopically try and inject voriconazole into the cavity in an attempt to kill the fungus or destroy the fungal ball. But the treatment, if the person is fit, is actually surgery, because that gives him a cure. So surgical resection in aspergilloma is something that is actually required. But like I mentioned in the beginning, there are issues with surgery because it is a little bit of a difficult surgery. And then those with tuberculosis who have progressive fibrosis because of recurrent infection, and recurrent hemoptysis is also an indication for surgical intervention. Coming to the second part, when do you say the person is fit for surgery? With elderly, and as we have an aging population, the risk for post-operative pulmonary complications will rise in these patients, and that is to be expected. Patients who are chronic smokers will also have a high chance of post-operative or operative complication. Associated comorbidities, diabetes or other comorbidities need to be evaluated, and then we need to look at lung function of these patients. So it's sometimes a crude thing that if you would say that Do all patients need lung function? If you have a healthy young person who can run 2 flights of stairs without getting breathless, you could indirectly say that his lung function is reasonably good to undergo thoracic surgery. But you should have more objective parameters as far as lung function is concerned. And some patients may require preoperative bronchoscopy for endobronchial assessment to make sure that there is no airway related disease which you don't want to get surprised on when you are doing surgery. So basically you're looking at mechanical function where you look at forced vital capacity and FEV1. As of now, the best parameter to look at is the FEV1. It gives you an idea of both the degree of obstruction and the degree of restriction. So if you have to go by one parameter, is the forced expiratory volume in first, second, which is usually taken for deciding as far as surgery is concerned. And you also look at the diffusion capacity as far as parenchymal lung disease is concerned. In some patients, we do a cardiopulmonary exercise testing when they are borderline. And then we look at the combination of FE1 and DLCO to decide whether the patient is fit for undergoing surgical resection. Predictive post-operative FE1 and DLCO should also be calculated, and sometimes it is worth doing that. We can also do what is known as a radionuclide perfusion scan. So you do just a perfusion scan, it will give you an idea of what is the perfusion of the normal lung and the lung that you're going to resect out. And you can calculate the predicted post-operative FE1 by a formula of preoperative FEV1 into 1 minus fraction of the total perfusion for the resected lung. Remember, you may have a good vital capacity, you may have a lower vital capacity, but you may find that this is predominantly by the normal lung. The resected lung is not at all contributing to the FEV1 because it's a destroyed lung, and therefore your cutoff may vary because there is hardly any perfusion or ventilation into that destroyed lung. So sometimes it is important. This is not commonly performed. I remember long time back, we did a thesis and Dr. Bal was the chief guide where we did this, looked at predictors of post-operative lung function in all patients who went for thoracic surgery, and we did find a good correlation between the pre-operative lung function prediction and the post-operative lung function prediction, which we did almost 6 weeks, 4 to 6 weeks after the surgery. So this can be used when we have a borderline case. For lobectomy, and the common method that is used is that you look at the predictive post-operative FE1 is equal to preoperative FE1 into 1 minus Y by Z, where you look at the number of functional segments that are going to remove, divided by the total number, that is 19 that we have, and that gives you an idea of the predictive post-operative FEV1. So you have various parameters, you can combine the two, and if both of them are more than 40%, the risk is average and you need no further testing. If it is less than 40%, the risk is high, and there you have a mortality which may be significant, and you should consider less extensive surgery or see whether you have other options available. If it's a combination, then you may need a cardiopulmonary exercise testing. And basically, if you want to have some ballpark number, then the mortality risk of 5% is expected if the post-bronchodilator FEV1 is more than 1.5 liter in patients who are scheduled for lobectomy. So you would ideally want an FEV1 of more than 1.5 liters if you're going for a lobectomy. Some people may take it up to 1 liter, and then some guidelines mention that if it's between 1 to 1.5 liter, do an ABG, and if the ABG shows that the oxygenation is good and there's no CO2 retention, you may even bring it down to about a liter as far as lobectomy is concerned. For a pneumonectomy, the post-bronchodilator FEV1, usually ideally you would like it to be more than 2 liters. Cardiopulmonary exercise testing is something that we do for patients who are going for surgery. It's a tool which is not freely available in most centers. As a matter of fact, I try to find out who else is doing CPET in Delhi, and we are the only government hospital which is doing cardiopulmonary exercise testing, and there's only one other private hospital which is doing cardiopulmonary exercise testing. And there are very few centers I think hardly any centers which are routinely doing cardiopulmonary exercise testing as far as a routine lung function is concerned, and I think we are probably the only center in North India which is doing cardiopulmonary exercise testing. So it's an excellent tool to measure overall functional assessment. You measure the VO2 max, that's the maximum oxygen consumption in 1 minute, and a patient with VO2 max of less than or more than 15 ml per kg have an average risk of complication, while if it is less than 10 ml per kg, the risk becomes high, and this is associated with higher mortality. So this is what we do in our pulmonary rehabilitation setup. We have the bicycle ergometer where we monitor the patient, and the patient is usually hooked up. He is made to cycle. We see his basic parameters, including his heart rate, ECG, blood pressure, and we also look at the VO2 max and look at the anaerobic threshold and evaluate that in terms of his fitness for surgery. So this is how it looks at when the patient actually does the cardiopulmonary exercise testing. What should we do to optimize patient prior to surgery? Definitely they should be asked to stop smoking. Good physiotherapy using incentive spirometer, adequate physical activity, optimized therapy if the patient has COPD or bronchial asthma. If there is a patient has steroid dependent asthma, you would require to increase the dose of steroid while the patient goes for surgery, because surgery itself is a stress which may lead to worsening. Not all patients require to be given salbutamol nebulization regularly 6-hourly. It may actually cause tachycardia, and therefore I think we need to be judicious in our use of nebulization. This happens everywhere in most ICUs. Patients have started on nebulization even if they have no chest problem as soon as they are come into the ICU. So all patients don't require nebulization unless it is actually indicated. Intraoperative assessment, some patients may need intraoperative bronchoscopies. We've done that in some patients who have required intraoperative bronchoscopy, especially in patients with aspergilloma and hemoptysis. And finally, post-operative assessment, sometimes we need to do that if there's an air leak or hemoptysis, and usually a flexible fiber optic bronchoscopy is all that is required. Sometimes if there is bleeding or there is actually a stump blowout or there is leaking from a stump, then you need to do some procedures that we do for some of these patients, like endobronchial blockers, endobronchial glue, autologous blood patch through the intercostal tube if there's a bronchopleural fistula, and sometimes re-exploration is also required. I think I'll finish here. Thank you very much. We'll continue with it.
Thank you, sir. Next, I'll call upon Dr. Ankur to tell about the pulmonary imaging.
Good afternoon, everybody. In the next 5 to 10 minutes, I'll try to give a brief overview of the role of radiologist in inflammatory diseases of the lung and pleura. So starting with the commonest thing which we see day in and day out is the post-infective sequelae, usually secondary to tuberculosis but can be seen secondary to any infection. So as has been discussed already, the sequelae are most commonly seen in the upper lobes. So as is seen in this chest radiograph, we can see there is presence of bilateral fibrobronchiectatic changes more on the left side. There is marked pleural thickening on the left side, the bilateral hyla are pulled up. So this is classical sequelae of old infection, no active infection, but these patients would remain symptomatic because the sequelae themselves cause a lot of symptoms. They may lead to hemoptysis. It's a nidus for recurrent chest infections. So further, all these are different patients. So in this particular case, we can see there is presence of these thin-walled cavities with surrounding architectural distortion and fibrosis. So the disease can be localized to a particular lobe or can be diffuse, and as has been discussed, if it is localized, becomes a candidate for surgery, whereas diffuse diseases become problematic, and so the only treatment option in such cases is palliative. So when these patients present with hemoptysis, and if the patient presents to the ED with massive hemoptysis, the only thing we can offer is an immediate bronchial artery embolization for palliation of the hemoptysis or to decrease the hemoptysis. So these are just few examples, the various findings which we see on DSA in these patients. So sometimes there can be just abnormal parenchymal blush in the areas of fibrobronchiectasis, or there can be a significant shunting either into the pulmonary artery or vein. So depending on what are the findings, various embolizing agents are used. Commonly we use PVA particles, but sometimes glue is also used. And if time permits, if there is submassive hemoptysis, we prefer to do a CT angiogram before. And CT angiogram enables us to find out the abnormal arteries, the location, so the time of procedure, the DSA procedure actually comes down and it becomes more comprehensive. Another complication which develops in these pre-existing sequelae of infection is aspergilloma. So aspergilloma is a soft tissue attenuation lesion which is present in the pre-existing cavities, and usually these are thin-walled cavities as a sequelae to infection. So sometimes the patient can be lucky that the surrounding lung is completely clean. We do a prone scan to further say that this soft tissue is mobile, it is not attached to the wall, so it is not a malignancy, it just drops on doing a prone scan. But sometimes things get complicated. So there is, as in this case, there is lot of pleural thickening surrounding it, there is lot of vascularity, and as sir pointed out, these patients bleed a lot from the chest wall. This is because this incites lot of inflammation, there is lot of pleural thickening, the posterior intercostal arteries are all enlarged, hypertrophied, and this leads to bleeding during the surgery. So this was an example of CCPA, that is the chronic cavitary pulmonary aspergillosis, which is a complicated form different from the simple aspergilloma. So further cases, as you can see, there is such a bunch of vessels arising from the abnormal bronchial arteries, the intercostal arteries. Coming on to the next pathology in the spectrum, hydatid cysts. So sometimes the hydatid cysts can be very clean, so there is complete fluid attenuation lesion bilaterally seen. Usually they occur in association with the liver hydatids. Sometimes we may be able to appreciate the membranes within, which are seen in these MR images. And when these cysts rupture, they will have air within them and there will be surrounding consolidation. So in follow-up, supposing, so this was a patient who had very clean-cut lesions in the initial radiograph. But however, when the hydatid cyst ruptures, there will be presence of surrounding consolidation. The membranes are ruptured, so they will fall down to the dependent areas, and lot of surrounding consolidation would be there. And on the other side also, we can see due to presence of aspiration, hemopsis, there can be findings on in the other lung as well. This is another complication which can occur because of the erosion of the wall of the arteries due to the presence of inflammatory pathology. So this is a pseudoaneurysm arising from a branch of the pulmonary artery. In these cases, percutaneous management which we can offer is that we puncture the pseudoaneurysm using a thin Chiba needle. We inject contrast to check the location that we are within the pseudoaneurysm, and the backflow also acts as a guide. And then we can inject thrombin or glue to close the pseudoaneurysm. So actually this is more of a life-saving procedure because immediately it can be done. However, many such cases eventually need surgery because the source or some neck, if it remains patent, then it will again fill up and will eventually require surgery. Coming to almost the last slide, so these are few examples of chronic empyema, and has been mentioned out, there are various stages of the parapneumonic effusions. It is important that if intervention is done early, that is in the acute exudative stage, the percutaneous drainage procedures may be helpful. However, if the patient has already progressed to a fibrinopurulent stage or an organizing stage, then even percutaneous streptokinase and all are not going to be helpful. So like in this particular case, the first case, there is thick rim of calcification around it, and such patient would obviously need surgery and would not respond to any of the other measures. These are other examples showing marked pleural thickening, presence of loculations. So if this is the ultrasound picture with so much septations and very little liquefied component, patient is unlikely to benefit by percutaneous drainage techniques. However, if the disease is not so bad, then percutaneous catheter insertion can be done and streptokinase can be instilled. Another example of a rare entity, as sir already pointed out, that hydatid disease is something that the patient comes with recurrence again and again, and this was one such case where there is presence of pleural dissemination of the hydatid disease, and this is like pleural hydatidosis, so multiple locules of fluid attenuation can be seen. So this was a post-operative patient. This is just to show the post-pneumonectomy imaging. So the space which is created by resection of the lung gets filled with fluid, and we have to serially monitor the chest radiographs that the fluid is not increasing, that the air fluid level is not increasing, or the mass effect is not increasing. And sometimes these patients may develop hemopsis in the post-operative period because some hypertrophic bronchial artery in the stump may be bleeding. And this was one such case where there was a hypertrophied right intercostal bronchial trunk which was subsequently embolized and the patient was treated. Another post-op complication which we sometimes see is a bronchopleural fistula. So supposing the air leak continues, so this is one such case, this is one such indication where we have to detect a bronchopleural fistula. So this is also a post-op appearance in the procedure which has been shown, that cavernostomy procedure where the latissimus dorsi flap has been insinuated between. And notice that the destroyed lung can be seen, the vascularity is still there. And so the post-op appearance, one has to be well versed with the post-op appearance, and serial imaging is usually done by radiographs. Thank you.
you, sir. Now I call upon Dr. Puneet Khanna to deal with the surgical anesthetic challenges in pulmonary resection.
I will be speaking on behalf of Professor Lokesh due to his untimely demise of his father today morning. I'm Dr. Puneet. I'll be going through the challenges in anesthesia. Pre-operative assessment carries an important part before we go ahead with the surgery, taking a comprehensive history and examining the patient, cough, type of cough, dry or productive sputum, breathlessness, grading, hemoptysis, quantifying the hemoptysis, whether the patient has got existing V's, optimizing the V's. Cigarette smoking, patient has to leave cigarette smoking over a period of weeks, months. It creates an impact and patient improves in the PFTs. Air pollution plays an important role as per the latest guidelines or the latest consensus that have come up. It falls into category 1. The usual scenario is an infection, hemoptysis, lot of secretions. We give general anesthesia, we need a one lung ventilation. So the non-dependent lung is collapsed in which the surgery is carried out and non-ventilated. Usually the position is lateral decubitus depending upon the site, right lateral decubitus or left lateral decubitus. Chest may be open if you are doing an open thoracotomy or maybe closed if you are doing a VAT surgery. Normal investigations that we carry out are hemogram, TLCs, DLCs, X-ray chest, a room air ABG helps us, pulmonary function test, a pulse oximetry, liver function test, renal function test and a CT chest. Sorry. How does relieving smoking help us and treat the respiratory infection? Loosening of the secretions occurs, inhaled nebulizations, bronchodilators are given, chest physiotherapies and postural drainage is carried out. What are the further risks? There is a chances of a potential bleeding from the major vessels. Post-op and intra-op pain relief is really important in these cases. We carry out invasive monitoring in such cases and there might be a need for post-op ventilation. So as per the PFT, very comprehensively we can say if FEV1 is greater than 2 liters, we can go ahead with a pneumonectomy. If FEV1 is greater than 1.5 liter, we can very comfortably go ahead with a lobectomy. These are certain recommendations according to the PaO2, PaCO2 and DLCO. The normal PaO2 is 90, PaCO2 is 40 and DLCO is 100. If we want to go ahead with a pneumonectomy, if a patient has got a PaO2 of more than 80, PaCO2 of less than 45 and DLCO of greater than 60, we can comfortably go ahead with a pneumonectomy. Lobectomy can be carried out if a PaO2 of more than 70, PaCO2 of less than 50 and DLCO of greater than 40. A segmental resection can be even carried out at a PaO2 of just greater than 60, PaCO2 of less than 55 and DLCO of greater than 40. As Professor Guleria had explained comprehensively, the CPET lobectomy, if VO2 max is greater than 15 ml per kg per minute, we can go ahead. Pneumonectomy, if post-operative VO2 max is greater than 10 ml per kg per minute. What we do is we have to isolate the lung. We either have double lumen tubes, most commonly used are left-sided double lumen tubes or a right-sided DLT. In case of we are not able to place endobronchial double lumen tube, we go ahead with the bronchial blockers. They are univent, Fogarty catheters or ANT blockers. These are the double lumen tubes which we use to isolate the lung. Left DLT, a left double lumen tube is most commonly used. The bronchial lumen is usually longer. It has got a symmetric cuff. It has a margin of safety than the right DLT. That's why we use the left DLT. It is easy to apply suction and CPAP to either of the lung. It is easy to deflate the lung with the left DLT. And it has got lower bronchial cuff volumes and pressures. And it can be used to isolate both the right side and the left side as well. These are some photographs of the DLT. right-sided DLT, Fogarty catheter. How do we manage a one lung ventilation? Initial management of one lung ventilation is always to check or confirm the position of a double lumen tube with a fiber optic bronchoscope. We try to maintain a two lung ventilation as long as possible till this, we can go ahead with it. We increase the FiO2 starting from 0.5 to 1, and which increasing the FiO2 helps us to increase the PaO2. A tidal volume of 6 ml per kg can be given. Pressure control ventilation, volume versus volume control ventilation, as far as the prognosis is concerned, both are the same. Any of the modes can be used. And respiratory rate is adjusted to keep the CO2 the normal limit of 40 millimeter of Hg, and there is continuous monitoring of oxygenation and ventilation. Serial ABGs can be done, and a PEEP or a CPAP can be applied to the dependent lung. What are the common causes of hypoxemia? Why does the patient desaturate while we give a one lung ventilation? It's a diseased lung, and patient having comorbidities. Most commonly intraoperatively, if you have started off with the surgery, the saturations are maintaining and patient suddenly desaturates. The most common cause is a malpositioning of the DLT. You have to put in a fiber optic scope and check out the position, whether it is in a correct position or not. There is a possibility, like if you are operating upon an infected lung, it may be there will be a lot of thick secretions or the blood which will be coming up during resection, which may block your ventilation through the DLT. Analgesia plays a very important role during thoracotomies. The analgesia of choice is basically a thoracic epidural if you would like to place it at a T4 or a T6 level. Usually 3 to 8 ml of 0.1 to 0.25% bupivacaine is given. You can choose either between morphine or fentanyl. IV paracetamol and NSAIDs are given to supplement it. Post-operatively, you can give an intracostal nerve block. Paravertebral blocks have been applied, and patient control analgesia can be given as well. Post-operatively, this is the same table I think the sir had hinted upon. If it is greater than 40%, we can extubate the very well on the table itself if he is awake. If the PPO-FEV1 is between 30 to 40%, we can consider extubation based upon the exercise tolerance, DLCO, VQ scan, and associated comorbidities. If it is less than 30%, we should stage the weaning. We should electively ventilate the patient and extubate later on, giving good analgesia. So sum it up, thoracic anesthesia, you use a double lumen tube as a standard method of lung isolation. You have to use a fiber optic bronchoscope to check the placement of a DLT, proper suctioning to remove any secretions or blood. You give GA plus epidural for pain. IV anesthetics or inhalational anesthetics do have a significant effect on hypoxia. Intraoperative hypoxia should be anticipated in such cases and managed on a priority basis. Thank you.
Good evening. I'll be sharing our experience with inflammatory lung diseases from April 2012 to October 2016. A total 297 thoracic cases were done during the period, of which 87 patients had inflammatory lung disease. Most of our patients were males, constituting to 70%, and the most common median age of presentation was 29 years. Most of the patients were between 20 to 40 years of age group. 17 patients had pre-op comorbidities. Diabetes mellitus was present in 7 cases, hypertension in 4 cases. 54 patients had a pre-op history of ATT intake, and 11 patients had a history of smoking. Median BMI was 20.9%, and mean albumin levels were 4.21 gram. Median FEV1 was 2.2 liters, ranging from 0.7 to 4.05 liters. 40% of our patients had a BMI of less than 2, FEV1 of less than 2. And predominant symptoms with which the patient presented were hemoptysis and cough, with the median duration of 24 months. Most of the patients had right-sided involvement, and aspergilloma involved mostly the upper lobes, whereas bronchiectasis involved mostly the lower lobes. Most common pathology involving the lung was aspergilloma, followed by uh, empyema and bronchiectasis. There were few rare cases like bulla, bronchogenic cyst, hydropneumothorax, gossipyboma, and mucormycosis. 42% of the 42 patients also had associated pathologies in the rest of the lung during pre-op evaluation on CECT, which involves atelectasis, bronchiectasis, fibrosis, lymphadenopathy, volume loss, pleural effusion. And most of the patients were done using the open approach, and 11% of the patients underwent VATS resection also. According to the type of surgery, most of the surgeries were lobectomy or bilobectomies. Decortication was done in 13 patients, and pneumonectomy was done in 8 patients. And a few rare procedures were also done depending upon the patient requirement, like capitonage, cavanostomy, and excision of the cyst. Few special techniques were used during the procedures, like bronchial stump reinforcement in 11 patients. Transpericardial approach was used in 4 patients, anticipating a difficult vascular hilar access. There was a median post-op stay was 6 days, ranging from 2 to 42 days. And median blood loss was 600 ml, ranging from 100 to 4.9 liters. Median operative time was 195 minutes, ranging from 95 to 480 minutes. And our outcomes, there are no mortalities till date, but there is 42% morbidity, which involves 11 prolonged early cases, which constitutes 30% of the cases, and 8 patients had pneumothorax, constituting 21% of the cases. 4 patients had hydropneumothorax, 4 patients had pneumonia, and 4 patients had surgical site infections, and 2 patients had empyema, and 4 patients developed a bronchopleural fistula following surgery. There were 10 patients who underwent reoperations either during the same setting or after discharge. Of which 7 patients were reoperated once, and more than once. 3 patients were operated more than once. There were 7 readmissions, and for various reasons like space problems, surgical site infections, or fever. There were 2 procedures. Two of the procedures was abandoned due to desaturation of the patients on table. Our mean follow-up period of 15 months, 23 patients have been lost to follow-up, 40 patients are asymptomatic, and most of the patients complain of mild to moderate chest pain. Rest of the a few patients complained of persistent cough. 2 of the patients complains of hemopsis. 3 patients has wound discharge. 2 patients have dyspnea, and 1 patient developed seizure disorder after the. But the correlation is not found. We also compared a few parameters of inflammatory lung surgery, inflammatory thoracic surgeries with non-inflammatory thoracic conditions, like mean operative time, which showed a considerable difference. Mean blood loss was 4 times that of non-inflammatory conditions. Mean ICD indwelling time was twice that in non-inflammatory conditions, and median post-op stay was 1.5 times of that non-inflammatory conditions.
Good evening. I'll just quickly take you through the review of literature as to what has been suggested regarding this disease in the published literature. We couldn't find any study which was suggesting inflammatory lung diseases as a composite, although there are various studies which are done on individual subjects like aspergilloma, or tuberculosis, or bronchiectasis. Mostly these studies, they are from the developing world. However, despite the huge burden from our country, the studies, they are limited in the literature. In the West, most of the studies which has been there in the literature, they primarily address the lung cancer surgeries and surgeries for COPD. Even the large meta-analysis, they include the surgeries from the developing world only. Coming to the study we did here, most of our patients, they are young and productive males, and this matches with most of the series which has been published. However, the picture is not same in the developed world, where they have a higher mean age at presentation of these patients. Our FEV1 BMI, roughly it matches with what has been published elsewhere, although the FEV1 is little lower. This is the kind of the patients we have. Nearly 30% of our patients, they had BMI of less than 18. This is one such patient in which the BMI was only 13. So, any site may be involved, but we have found that in some diseases, one side is more involved than the other. So as we have discussed earlier, also in bronchiectasis, we found that the lower lobes are more commonly involved, and this matches with the other published series. Similarly, in aspergilloma, the upper lobes are more commonly involved, and that again matches with the series published elsewhere. Interestingly, we have found 2 patients in which the inflammatory disease was not in the lung, but was in the mediastinum. And one of the patients was an mediastinal hydatid, which is very rare in anti-mediastinum, and the other one, it was a retained foreign body. The most common presentation is in the form of cough and hemoptysis. Again, various published series, these are the most common symptomatology. Interestingly, again, some of the series which have been published from West, they have included the patients which are primarily asymptomatic, but we couldn't find any such patient in our series, as well as some of the series which are presented from the developing world. Because of adhesions, primarily these patients, they're not suitable for VATS. So these are the kind of adhesions they have. So primarily they are operated by an open approach. And this is again, it syncs with what has been published elsewhere. Like in all these series, and they're all recent ones, 2011, 2016. And most of the patients, they were primarily operated by open surgery. Although there has been interest in VATS, this growing interest in VATS, but in these studies, if you just go in detail of that, we have found that more than 50% of patients, they've been converted from VATS to an open surgery. Because of adhesions, these surgeries, they usually last a little longer than usual surgeries. And we roughly takes nearly 3 hours to complete one surgery, and this matches with the published literature. Similarly, the average blood loss is more. This is just a picture depicting the blood loss in one of our patients in OT. And the blood loss which we have in these patients is somewhere around 600 ml on an average, but has ranged from 100 ml to even up to 5 liters. But then this again matches with the published literature. We have a host of post-operative complications, and again, in various studies, the morbidity ranges from 8 to 54%, with a genuine rate of death in case of 5% of patients. So in all these patients, the morbidity is little more. Our morbidity, which we have found, is nearly 42%. These are various morbidities. Prolonged air leak is the most common of them, and the incidence is 0.7 to 35% in all the published series, and R is somewhere around 30%. Atelectasis and collapse in 4% of patients. Persistent space problem, like an impairment up to 15% of patients. Bronchopleural fistula in 15.8. Massive hemorrhage requiring reoperation in nearly 5% of patients. Wound infection is fortunately less, so it's somewhere around 3%. And nearly 2% can be respiratory triple even after the surgery. And seeing this, I must say that mortality as genuine, there is a rate of 2% nearly, 5% nearly. I'll just invite Dr. Rajnish to just sum it up.
So to summarize that, most of the patients in our CT are young males with cough and hemoptysis being the dominant symptoms. Majority of them have poor respiratory and functional reserves, mostly not suitable for VATS approach. They can have massive blood losses and near misses. We have been lucky that we have had no mortality so far, but we have had near misses, and it's predominantly because of the bleeding that occurs from the chest wall. And the other problem, major problem that we face is the post-operative space problem, because the underlying lungs are so bad that the remaining lobes do not expand well, and then they keep having these space problems. Next. Is there any other? So I would like to leave you with the thought, ladies and gentlemen, from inability to leave well alone, from too much zeal for what is new and contempt for what is old. from putting knowledge before wisdom and science before art, cleverness before common sense, from treating patients as cases, and from making cure of disease more grievous than its endurance. Good God, deliver us. Thank you very much. This line that from making the cure of disease more grievous than its endurance actually holds true for these people. As initially I showed you some picture where the patients at the end of the surgery are looking worse than what they were pre-surgery. Thank you very much, and now I open this presentation for discussion. Any questions, if there are any? Although we are a little over time, but we also started a little late. Any comments or questions, if there are any? So, if there are none, my only humble request is that these patients should be counseled regarding the seriousness of their problem, seriousness of surgery, and possible serious complication that they may encounter from their first contact with the physicians, so that they are mentally prepared for all this. Many a time these people come to us, we've been told that ये है surgery करा लो ठीक हो जाएगा, and surgery करा लो, but then they can just lose their life, and that's a real risk and real problem in these people. So that is, yes please.
Regarding this blood loss from the chest wall, did you ever try the organ for those patients?
We have organ in with the GI surgery people, and if it is available, then one can try. We have not had the opportunity to get it at the time when we need it. But I don't think it will really work very well, because you can actually see the blood spurting there, and you can't see it. You can't see the site, because particularly when it happens in the upper lobe resections. It's all right when it's in the lower, because you have a wider space, you can see, you can hold, coagulate. But when it happens in the upper lobe, we have used intraoperative telescope, 30-degree telescope, just to be able to see where is it coming from. But what happens is, I think they have massive collateral, they develop lateral holes, and they just go on bleeding. And you pack them, you do this, you do that. And we used all these glues and tissel and other things, and they just don't really work there. What is important is that we have learned that it's better to get the hilar control first before you go on to the chest wall. Otherwise, if they start bleeding both sides, then you are done for. So, hilar bleeding, if it occurs, you won't be able to do anything about it, particularly if the pulmonary artery is gone. So, but sometimes just to get to the hilum, you have to divide a lot of it just to get to the hilum. And 4 or 5 patients, we actually went transpericardial. First got the vessel from inside. The other problem is on the CT sometimes it looks very nice and fine, no? But when you go inside, there is no upper lobe, no middle lobe, no lower lobe. Everything is one. And in those patients, your planned procedure may move from a lobectomy to a bilobectomy to even a pneumonectomy. So if you are taken up a patient with 1.3, 1.2 FEV1 and you have planned a lobectomy, you don't find any separate lobes there. And if patient, God forbid, bleeds, then you have no choice but to do a bigger procedure, do a pneumonectomy and quickly try and get out. Those kinds of things. Yes, please. Because it's diffused. If it's a one localized thing, yes, but it just occurs from every single intercostal space. It's just bleeding and bleeding. The other problem is preoperative embolization has been shown to increase the risk of, particularly if you're doing it for hemoptysis and all, the bronchial stump necrosis. So it's a double-edged sword. I mean, if you do it, you have to do it at times, but then it has also been shown to increase the bronchial stump blowouts. And that is a very big problem. Once these bronchial stumps blow out, then the only choice left to you is sometimes go a step higher. Like you've done a lower lobectomy, you go a step higher and take the middle lobe, because you won't find a healthy bronchus at that level. And one patient we have had to go transpericardial and and that we did in CT-based OT. We had to re-amputate the pulmonary artery, mobilize the aorta to one side, SVC to the other side, to get the bronchus in between the two, and those kinds of things. So patient from coming to you with once or twice a hemoptysis lands up with these problems, it's a major thing. And we wish to express our gratitude to the Department of Pulmonary Medicine who have been very cooperative. But we definitely wanted to bring out these issues because patient should not come here thinking, yeah, all right, छोटा सा operation हो जाएगा. Thank you very much. Thank you, ladies and gentlemen.
Very good.